Assalamu alaikum, rahmatullahi wa barakatuh. My name is Rola Ba-Abbad. I'm one of the consultants in the Department of Retinal at KCASH, and today I'm going to speak about the signs and symptoms, but not as a didactic lecture, because I know that some of you guys will be very dedicated and taking notes and so on. But actually, I thought I would rather put this within the context of what is the role of the general ophthalmologist when they face a patient suspected to have an inherited retinal disorder. Because if I give you signs and symptoms, this is something that you can come across in any textbook. But then when you see the big picture, you will be able to grasp the idea. And then we can hopefully, inshallah, during the next series of lectures actually delve deeper into more, concrete signs and symptoms. So this is, I hope that you consider this as an introduction at the beginning of 2022, and then we can take it from there. So let me just minimize this. Okay, so how would you define inherited retinal disorders? So for a starter, I wouldn't say disease, because it's a disorder. Sometimes it's not something that people contracted. It's not an infection or anything. It's not but it's rather actually a disorder of some of the retinal cells. And then eventually this will lead to visual dysfunction. So if you think about it from this point of view, you should be able to consider patients with stationary as well as progressive disorders, progressive retinal dysfunction, to have an IRD. So generally, it's a group of heterogeneous conditions, and it's actually more common than what you would think, because the published data initially, the statistics suggested that it affects at least 1 in 3,000 or 1 in 4,000 people in the whole world. But actually, now that we have more allele frequencies of several genes in the normal population, then the carrier frequency data recently collected actually suggests a higher prevalence of about 1 in about 1,400 individuals. So you would expect about 5.5 million people to have an inherited retinal disease. So that's not a small amount of patients. And despite that they are called orphan or rare disorders, they are no longer orphan or rare, and they should, be given more attention. And it goes without saying that such disorders have significant impact on the patients, their families, and the society in general, because of the resources, because of the associated disorders, the associated comorbidities, and also the associated psychosocial effects. As you will know, there are quite a few disorders that can be also associated with syndromic features, simply because the same gene is important for several organs in the body, and then any disease-causing variant in such genes can affect several systems in the body. So why it's important to suspect IRDs when you have signs and symptoms suggestive, and why it's also important to take the patient word seriously and investigate the patient before you can declare that this patient might be malingering or faking symptoms. So quite a lot of symptoms can lead to misdiagnosis of optic neuropathy as an inherited retinal disorder and vice versa. That's one thing. But the other thing is that simple things as even refracting a patient properly can lead to misdiagnosis as an IRD. And I've come across patients who have been referred to the IRD clinic, suspected dystrophy, and the simplest thing that wasn't really done properly was good refraction. And then you refract the patient, and patient is corrected to 20/20, and the symptoms are gone. So before you suspect this, or before you even think that the patient is malingering because the retina looks fine, dig deeper. Some patients can also have symptoms at very early age, and that would make it a lot easier for the clinician to suspect an IRD. But what if you have a patient, a 60-year-old patient who develops, reduction of central acuity. And it's funny enough that some patients, for example, with long-standing Best disease might actually, progress to an atrophic stage without actually being known to have Best disease, for example. And then you end up with somebody with macular atrophy, and you don't know whether this is like dry AMD or even a very, very mild form of Stargardt disease. Some mild mutations, the hypomorphic alleles, can also lead to adult onset symptoms. And sometimes, when you tell them it's inherited, they will just like stop and say, but there's nobody in my family or my parents' family is knownly affected. And this can also lead to delay in the diagnosis, because most of the people do not really think of recessive inheritance, especially patients. Clinicians might think of it, but the patients themselves can live in denial for quite some time, because nobody else in the family is affected. And this can also lead to delay in the diagnosis. Another thing is that sometimes the associated comorbidity can make the visual problem the least of the patient's problems. So if a patient is confined to a wheelchair or a buggy, and they never developed proper appropriate psychomotor features, development signs, and they haven't even learned to walk or talk, then really, having a roving eye movement or absence of visual behavior doesn't really come at the top of the list of the family or even the treating clinicians. And therefore, the diagnosis can be delayed for years. So the patient journey starts from several places. It can start from the pediatrician office, soon after birth, during the first or second postnatal checkup. It can start at the office of the general practitioner when the parents, raise concerns about the patient, or even at the optometrist's clinic, where actually the first symptom would be that the kid is like having a checkup before going to school, and then they find that the vision is not correctable to 20/20. And then series of investigations, is instigated. So subnormal vision can manifest, the easiest thing is to see a child with nystagmus or roving eye movement. And I noticed that quite a lot of those patients end up in the neuro-ophthalmologist office. And automatically it becomes like an automatic reaction to refer those patients to have an MRI. So I was just, thinking loud here, like whether, what's the rate of finding an MRI abnormality in those patients amongst those with retinopathy, for example. So would it be appropriate to start with an ERG and then proceed to MRI if the ERG is normal? That's also a question that always, crops in my mind whenever I see those patients, the young patients. Obviously, a child who doesn't really smile back when the mother smiles to them, or when they start reaching out, they don't reach out to something presented to them unless they hear a sound. Or when they start crawling, for example, or walking, they start bumping into objects, or they stop playing when the lights are down, for example, then the family would suspect that there is some abnormal visual behavior, visually guided behavior, and then the patient gets referred. Obviously, patients can also have severe aversion to bright sunlight, or, to the extent they can't really go outside, or they close their eyes completely. So these are all, symptoms that the parents or the relatives might notice. Sometimes, things go the other way around. So say, for example, whoever attended our grand round with Dr. Malak Al-Ghamdi, who's a consultant in genetic and metabolic disorders, she mentioned that most of the time when they have a patient with syndromic features, they usually refer the patient to the ophthalmology clinic to rule out any abnormalities. So sometimes when the general pediatrician or subspecialized clinic is working up a patient, they refer also to ophthalmology to rule out any abnormalities, and the journey can start from there. And obviously, patients who are adults and they start to have symptoms in adulthood, they can just show up to the clinic and seek help. So what's the role of the general ophthalmologist at this stage? Really, I mean, it's simple, yet you have to tackle it in a very systematic way, and you put the hat of the investigator, on, because these patients neither need laser nor injections. They just need somebody who can listen to their symptoms and elicit good history, and then try to formulate a list of differential diagnoses, and based on that, they guide the investigations. So not everybody with Usher syndrome, for example, is deaf-mute. So some patients, if you speak to them long enough, you will notice that they have a lisp. So when they speak to you, all the high frequency letters like the S, Z, in Arabic, Sad, Sin, Zain, these letters are actually pronounced as TH. So they would say, Assalamu alaikum, something like this. And that's not because they have a lisp. It's just because patients with Usher syndrome type 2, for example, they can still hear, but the hearing loss is mostly affecting the high frequencies. So this is the way they learned to speak. This is what they heard, and this is how they start speaking. And then when they walk inside, in your office, and you just have a short conversation with them, sometimes they are shy. So and the family member or whoever comes with them takes the lead in talking to you, and then you should actually try to gently, direct the conversation with the patient themselves. Listen to them, what they have to say, how they formulate their sentences, how coherent they are. Ask them to put their mask down and look at their teeth, and people most of the time, they will find it funny. So make use of all of these opportunities to establish a rapport with the patient, but at the same time, work your way through, finding features. So obviously, not everyone will tell you I have renal disease, but sometimes the patient, arrives to the ophthalmology clinic after having a renal transplant. And it never occurred to the nephrologist or who followed them up, or even the surgeon, the transplant surgeon, that this might be something related to an ocular problem. And then it manifests later on, or it's actually manifested at the time, but then the severity of the renal failure was actually the first thing that actually brought the patient to medical attention, and then the ocular condition, came next. So if you don't put one and one together, you're lucky if you pick up a diagnosis early on before the renal dysfunction, becomes really obvious, and you're the one who alerts the patient physician to such a possibility. But it works both ways. And obviously, you need to know a few things about syndromic facies. So, from medical school, for example, somebody with trisomy 21 is very obvious to spot. But there are also conditions that are available in the clinic that actually, taking a look at the patient's face and then ask the parent or the siblings to, show their faces as well, and then compare. There are certain, syndromic features that you can pick up, and you can make a diagnosis like Cohen syndrome, for example, by just looking at the patient's face. Even some patients with Ba-Abbad syndrome might have also slightly, coarse features compared to the family members, and this has been already reported in the literature. If you see the papers by Professor Feldbeams. So some of those patients, just looking at the facial features can give you a clue. Obviously, patients with the metabolic disorders might come with sorts of, supplements or medications that, they show it to you, and they don't think that it's related to what they have. So sometimes they don't even volunteer giving you this history. So you have to sit and really listen to them and dig deeper into what they are taking, what other symptoms. Say, for example, I had a patient on several anti-epileptic medications, even the patient developed some sort of personality changes and psychotic symptoms. So the patient also was placed on antipsychotic medications. And eventually, when you put one and one together, this patient came to me with optic neuropathy. You direct the genetic testing, and lo and behold, you make up a diagnosis that the patient and the family were never, aware of. And probably this might also explain why this patient, for example, one of my patients was put on every anti-epileptic medication that you can think of, and yet the epilepsy was never controlled. And this is also a form of encephalopathy that can be associated with certain inherited disorders that affect the retina. So obviously the thing that we all think about is polydactyly. Don't forget that polydactyly does not have to be in both hands and both feet. You might end up with only one extra toe in one foot, and the other foot is completely normal. And patients don't really volunteer taking off their shoes and socks. So if you suspect it, just take a look. Sometimes if you ask the patient, if they are adults, probably they don't remember anything because they've been operated early on. If the parents are around, they might give you this information, but sometimes they don't. So check. Another thing that also can be also associated with inherited retinal disease is acetabular dysplasia. So the parents probably may not even think about why the patient, for example, can have a problem with walking, and then they've been diagnosed with khal' al-wark or acetabular dysplasia, and then when you elicit the history, they will tell you, okay, my kid just walked at the age of 8 years or even 4 years. So then you have to dig deeper. Is it because of the vision? Is it because of, and then again, there is another form of ciliopathy that can be associated with this. So this all can help you tremendously just listening. Looking at the fundus is not going to help you with anything, at this stage. You have to just listen to the patient and ask tactful questions, read a bit about also all these disorders, so you can actually, run through a list of differential diagnosis. If you don't really have this, background about such disorders, it's really difficult for you to make the diagnosis. Okay, and then you assess the vision. You request the ancillary testing as you see appropriate, visual fields. Sometimes, if you don't have visual fields available for a reason or another, it's a busy practice. The service is also, congested with patients from several subspecialties in the hospital. Then it doesn't really take you so much time and effort to just do a confrontation visual field and just write down your findings. You'll be surprised, that at least if you can tell from the autofluorescence that the visual field is quite constricted, for example. But if you demonstrate this to a patient who drives and tell him, look, my finger is just, half a meter away from your face, and yet you couldn't see it wiggling. How about a human being just passing in front of you while you're driving? Because those patients are really difficult to convince to quit driving for their own safety and for the safety of the passengers and pedestrians. So, if you make this point to them, one thing for you is to document the visual field and document in your notes that you also discuss driving with the patient. And the other thing is that the patient themselves now are aware that there is a problem. Okay. And then you request electrophysiology because you have a clinical question, not because the patient has got an IRD. You have to have a clinical question that you are seeking an answer from electrophysiology. If you see a patient, for example, with, widespread bone spicule pigmentation, outer retinal changes, the blood vessels are completely attenuated in the periphery. Without doing an ERG, you can tell that most of the outer retina is already atrophic and it's going to be dysfunctional. Is it really useful for the patient at this stage, especially that we don't really usually request tests for macular function like pattern or multifocal ERG. And the macular function doesn't contribute anything to the full field ERG. Does it really help at this stage to actually find out whether the ERG is undetectable, or you can detect at least 10 microvolts of response? Is it really going to change your management? Is it really going to direct your investigations? So think about, formulate a question for the electrophysiologist to answer. And again, the utility of EOG. Do you suspect that this is Best disease? What's EOG useful for example? Because if you request EOG in a patient with retinitis pigmentosa, for example, if you know the cellular origin of EOG, you would know that abnormality of the scotopic function, the rod function, will automatically, if it's severe enough, it will automatically abolish the EOG. Unless you have a question, is this Best disease autosomal dominant or autosomal recessive? Am I dealing with something like Azure, for example? EOG does have a very, very limited role in diagnosing patients with IRDs, unless you have a very clear clinical question that is correlated with the pathophysiology. And obviously, it always gives you an idea about, what the macula looks like, whether there is macular edema or there isn't, and what the ellipsoid zone and the retinal lamination look like. You always request multimodal retinal imaging. In our hospital, for example, we do regularly fundus autofluorescence, pseudocolor, and OCT. And then you have an idea about what you're dealing with, and then you refer the patient to the IRD specialist. One thing that you can say to those patients, you prepare them to what to expect in the dystrophy clinic, but also try not to give them too much information about treatment, because even patients with RPE65 retinopathy, not everybody would be suitable for treatment, and it becomes really frustrating for the patient and the family, because you give them little information, and you tell them that once you see the IRD specialist, they're going to treat you. It becomes really difficult to counsel those patients and bring those with high expectations down to the realistic level. So it's better to tell them, okay, we've got an idea about what you have, but we need to refine the diagnosis and take it from there when it comes to your management, and that's why we're referring you to the IRD specialist. So what does the IRD specialist do then? So one thing is that ERG is not everybody's bread and butter, which is fine. I mean, I cannot read brain MRI with sufficient skill to give a diagnosis, which is absolutely fine by me, because there is a radiologist there to interpret the data for me. And same goes for ERG. Even if you know what normal ERG looks like, you have to take into consideration several factors, and this has been already mentioned during my ERG course, which will be, I think, repeated also this year. So first of all, even to interpret the ERG, you have to also understand the cellular origin of these responses, and then what happens if something goes wrong in the retina. So, refining the phenotyping and accurate interpretation of the data is something that the IRD specialist does for a living. And such disorders are so rare, and particularly certain phenotypic-genotypic associations are really difficult to narrow down the differential diagnosis, and therefore, requesting a vision panel for everyone who walks through the door is not really going to be that helpful in certain situations, especially when there are always surprises. And also sometimes it helps if you know the features of certain disorders, for example, choroideremia. So choroideremia is an X-linked disease. And, the trainees who come to my clinic usually are familiar with my question about what are the X-linked retinal disorders that and which one of them actually the female carriers show signs of. Well, you get the occasional family where the proband is a young man who's been diagnosed, for example, with choroideremia, and the family were counseled along the terms of autosomal recessive disease. It becomes really difficult to convince the family that it's extinct, and then you bring the mother along and you examine the mother and you show her even her own fundus photos. So what's the benefit of doing this? So because it becomes really a different story, an extinct family pedigree is different from a recessive pedigree. You have to counsel the mother about her daughters. You have to counsel the mother about her own sisters, and you have to trace it, whether it was actually the maternal grandfather who passed it on, or it's actually a series of female carriers through the family. What's the benefit of that? Well, although gene therapy trials have not really reached to a conclusive result when it comes to transiting to or translated into an FDA-approved treatment, but I think there might be something in the way, and suspecting or identifying other family members at a sufficiently young age might actually benefit the family in the future. So, if you happen to be at a medical retina clinic or a pediatric clinic, it becomes really too busy for you to examine several family members and try to formulate, these questions and give the family correct counseling, and that therefore actually, give the patient the chance to go to the RD clinic to be properly examined and the family to be properly counseled and examined as well. So what does the IRD specialist do after phenotyping? They genotype. So choosing the appropriate genetic test, and that doesn't mean always that we pick up a panel. Sometimes we request whole exome sequencing, but then we try to guide the clinical genetics lab to what we think is happening. So if the patient, for example, is suspected of having Cohen syndrome, we can say, okay, abnormal facial appearance, short philtrum. We are suspecting question mark Cohen syndrome, so on and so forth. So sometimes, the lab will just put the extra effort. Say, for example, a patient who underwent even whole exome sequencing, and it came back, when the patient has got retinopathy, and it came back with a variant of uncertain significance that causes like keratoconus or something, if I remember correctly, something completely unrelated. And it's not even, the patient didn't have keratoconus, the patient had, retinopathy. And there was a very good reason to suspect that this might be related to transmission between the photoreceptors and bipolar cells, because the patient had clear electronegative ERG. But whole exome sequencing didn't show anything. So then I wrote to the lab and I said, let's look at CSMB genes, closer. And then when the lab looked actually, and they did actually deletion duplication analysis, they found the whole deletion of a gene called CABP4 that caused this phenotype. So if you did not phenotype the patient, even having the most powerful and most comprehensive genetic test isn't going to help the patient or yourself, or even, the funding body who's, paying, money for such expensive tests. Always be prepared as an IRD specialist to deal with incidental findings. Say, for example, if you end up with a, BRCA1 or a BRCA2 mutation, if the patient has signed up, in the consent that, incidental findings should be declared to them. How would you deal with this? This is something also that the IRD specialist, together with the clinical geneticist, should be able to handle. Variants of uncertain significance, are they fitting the phenotype? Are they worth segregating or not? Because sometimes it becomes really a red herring, and you go around chasing actually the wrong gene. Well, the patient has got, a relevant gene, but it hasn't been looked at because there are variants of uncertain significance in other genes that kind of made everything noisy for the non-IRD specialist, and it kind of led to several unnecessary family anxiety and unnecessary testing for some of them. You have to also deal with negative results. So what would you do if the patients have got negative exome? And this is something that can happen. You should be able to understand the principles of segregation analysis, homozygosity mapping, and things like that. It doesn't always happen in the clinic. It happens behind the scenes, and you try to actually, aggregate as many raw data as possible and try to help the family. Sometimes you don't find the answer straight away, and that's okay, but it shouldn't be your norm. If it's your norm in the clinic, it means that you are missing something in the clinical assessment. And it's always good to bring those patients back and try to reassess again and take a fresh look at everything. We also are blessed to have in the service the genetic counselors. They chart the family pedigree more extensively than a busy clinician would be able to. is the family pedigree is quite helpful. It suggests the likely mode of inheritance. You can also trace other family members, and therefore you can actually reduce the cost of genetic testing for relatives and aid in segregation analysis. You can also, your genetic counselor should be able to help with counseling about reproductive options, taking the consent for genetic testing and explaining the implications to the patients and their families. And then counseling is actually a process that starts before genetic testing to bring patients' expectations to a realistic level, and then after genetic testing when they disclose the results. So there is also a service that we hope that at some point in time we can establish, which is basically the multidisciplinary team meetings. It's not a one-man show, it's teamwork, and it should actually be across several subspecialties, and that includes the clinical geneticist and also the molecular geneticist. And these meetings are especially helpful in patients with unusual phenotypes, variants of uncertain significance, patients with new variants in known genes, and also reanalysis of data or going for whole genome sequencing. This is a decision you shouldn't be taking lightly in case like your exome doesn't, disclose the data, let's rush for whole genome. It doesn't always give you the answer, and you should be able to have an idea about what to look for if you do whole genome sequencing. IRD patients, there is quite a lot at stake. We started the management in the clinic by actually speaking to patients about, for example, driving. And this is part of your management. You shouldn't think about management as something a clinician does as part of treatment. One thing that you have to take responsibility for is to inform the patient and also document this in the notes. And then those patients are obviously referred for low vision rehabilitation. You will be surprised how many patients have been put under the pressure to transfer from sighted schools to special needs school, and they learned Braille while they could have actually had an education as sighted people given the right low vision rehab and training and obviously equipment. Patients also, you'll be surprised, quite a lot of patients repeat the question whether actually is my IRD going to improve with glasses, or does it help to have, say, for example, refractive surgery? And sometimes you have to spend the time with the patient, explain to them what the retina does and where the retina is in the eye, and why refractive surgery, for example, would not bring the vision back to normal. But also you can use your clinic time wisely, because patients sometimes have more questions as they step outside of your office. So it's always helpful to have the patient health education on board and refer patients to them as you see appropriate. There are always support groups for, say, for example, retinitis pigmentosa and so on. And I think patient experience should be enhanced by having on board some health educators and volunteer physicians from time to time to guide the discussion and actually kind of dispel some of the myths that can be spread amongst patients. At the low vision rehabilitation, also the education and needs of patients are also addressed. And those patients also might need for social support services. So you can also support the family by doing carrier testing and premarital counseling when the results become available. Further management includes also suitability for gene therapy and gene trials, monitoring patients after gene therapy, and enrollment even of patients who do not have who are not suitable for gene therapy, or for their disorders there is no gene therapy available yet. You can enroll them into natural history studies to monitor progression, and you should be able to refer those patients to other medical specialists as you see appropriate. So there are several resources about the patient journey and the utility of genetic testing for patients, and I encourage you. I'm more than happy to supply you with more material if you drop me a line on my email. But this is the material that I have for today. Thank you very much for listening. Any questions? Is there anybody listening at all? You're welcome, Dua. Thank you, Dr. Noelati. I prefer somebody to talk to me because it feels so lonely here.
Yes, Doctora, we can hear you.
Thank you.
Thank you for the great lecture.
No problem. It's a pleasure always. Do you have any questions, any comments, anything that you'd like me to clarify further? Dr. Noelati says she's voiceless. I don't have the controls over muting people and things like that, but can somebody from control just Allah yafiki, Dr. Khawla. And thank you everybody for the nice feedback. بس نبغى نسمع أسئلة يعني. We want to hear questions because it stimulates thinking, Oh, I'm sorry. So Dr. Nulati, salamat, ما تشوفين إن شاء الله. Okay, so I think people are quite satisfied with what has been presented. Inshallah, I will, as I said, this is part of a lecture series, so this is just a warm-up for you guys, and inshallah we'll have more lectures about more, and I will be showing more data. Okay, if you have time, Dr. Nulati said you go over ClinVar if you have time. So that's a great idea. We can go over actually online resources like ClinVar and also public data like Nomad to show you how you can utilize those to actually find out if the mutations that you have at hand have been published or not. And we are, inshallah, in the process of actually applying to get the IRB approval to submit our own unique mutations actually on ClinVar. This will also, I encourage you all, once, inshallah, we get the approval to submit your data to us so we can upload them. Because if anybody, not every new mutation is publishable, because sometimes the variant is new, but the phenotype and everything else is the same. It could be just a private mutation to the family you are seeing, for example. This is quite helpful in actually, educating the general medical community about our own mutation spectrum. And also whoever comes across the same mutation anywhere else in the world will be citing the ClinVar accession number, and then KCash will be credited for that. So I encourage everybody, I will announce inshallah soon once we get the approval of the IRB, so you can all submit your novel mutations to us. And you can also, it doesn't really burn your card if you're about to publish it, because it helps the reviewer that once you publish it on ClinVar, it actually gives you an accession number, and you can say, actually, this is our accession number, and we've done our due diligence towards the medical community by submitting this. So it raises the prestige and the name of KCash. So I encourage you all to help with that, inshallah. So Dua Milibari was also keen to suggest how to read genetic test result properly. As I said, Dr. Dua, this is something that comes with experience. I mean, I can give you always guidelines. You've sat with me, and I think everybody who goes through the rigors of writing papers in molecular genetics or in clinical genetics should be able to have an idea about the skill. It comes with time, but it's as I mentioned, it's like being able to read the chest X-ray or being able to read an MRI. You have to have the proper training to do this appropriately. Dr. Muhannad says, as genetic testing is not readily available in many institutes, where do you advise families to do it and how much does it cost them, for West at least? So I'm not here to advertise for any companies, but there are services available here privately in the kingdom, and the price is actually fortunately getting down now. So, I think for Saudi families, certain labs for Saudis, they can charge up to 3,000 riyals, which is, a tremendous improvement from where we started. Say, for example, a few years ago, it was almost double the price. So as the technology improves, the prices will get lower and lower, makes it accessible to quite a lot of people. I hope this answers your question, Dr. Muhammad. Any other questions? دكتورة سلوى الهزاع. تفضلي دكتورة.
Thank you so much, Dr. Rola. This was really very informative. It was a nice start, as you had mentioned. I just wanted to sort of bring out something, to the listeners and those that are interested in genetics. And I wanted to get your feedback. Now with all this genetic testing, and we've progressed so much, and thank you for also mentioning there's a lot of private labs that are now doing these genetic testing, and they're actually doing it at lower rates than we expected. And hopefully the government soon will be forming also something that will be accessible to everyone, inshallah soon. But my question to you is sort of on a different subject. What's the role of ERG now that we are so advanced? And I know that before the genetic testing, I really relied on the ERG on many of my diagnoses, but now I hardly even look at it. I just wanted to get your feedback, and maybe also you can, shed light on that, especially to those who are now interested in genetics or on the starting point.
Sure. Thank you very much. So I think ERG can be useful in two ways, or at least two ways. So when I say ERG, I say also electrodiagnostics, because that can also include visual evoked potential. So it's not only testing the retinal function, you're also testing the function of the retina and the visual pathways all the way down to the cortex. So basically, for diagnostic purposes, if you happen to have a patient, for example, quite a lot of babies, for example, with nearly normal retina, who exhibit abnormal visual behavior, sometimes they undergo MRI because people are looking for any structural abnormality of the brain. And I think it's a logical step once the MRI is normal to actually go for an ERG. For a simple reason. Sometimes when you look at somebody's retina, you can't really tell whether it's actually achromatopsia or LCA or even congenital stationary night blindness. And believe it or not, if you send it to the lab, no matter how, the labs are at the end of the day, clinical scientists, and if you don't guide them by proper phenotypic data, they're going to be misguided. And I've faced this many times. I've faced patients with CSMB being misdiagnosed as LCA who underwent whole exome sequencing, and this is the example where I said that actually I guided the diagnosis. I said, this looks like a form of a synaptic disorder. Please look again at the West data, or even do deletion duplication analysis. So unless you know the phenotype, it's electronegative, if the retina is functional, if the patient, even for example, if they have nystagmus and you fail to diagnose them to have achromatopsia because you thought like, okay, what's the point of doing an ERG? And then the lab, you will tell them it's LCA. And even if they do whole exome sequencing, they will filter the data using an LCA panel. And this may or may not include achromatopsia genes. So again, the diagnosis is being missed. The family will be under the impression that their child is having a blinding disorder, and the child will be raised as a blind child while they are actually, just visually impaired. And, with a pair of good filter glasses, they could have functioned much, much, much better. So it helps quite a lot in making the diagnosis in the first instance. I have seen also patients with inner retinal atrophy, for example, who have been diagnosed as LCA. You look at the retina and you see that the inner retina is thin, but the outer retina is completely intact. You do the ERG and it's electronegative. So there might be something else other than something that affects the photoreceptors. And then you have to direct your search accordingly. If you don't do ERG, you see it electronegative, you cannot really put one and one together. That's another example. Another example is that patients, sometimes you look at the back of the eye, the disc is pale, and the retina looks okay-ish. Probably, atrophy hasn't kicked in. But then if you don't do ERG, you send the patient again for LCA panel, while the patient might have optic neuropathy, for example, severe form of optic neuropathy. And I've seen patients with LHON, which is completely atypical picture, because the patient is behaving like an LCA patient. But then you discover that once you do the ERG is normal, and then you should have directed your search to the optic nerve. And if you've done the combination of ERG and VEP, you could have isolated that this is a primary optic nerve disease, and you should have directed the lab for molecular genetic testing. So the ERG is really handy in such situations. Sometimes it can be tricky also in patients with autosomal recessive breast, and I know that Dr. Noelati will be quite excited when I mention this, because there are quite a few patients who do have atypical features. And unless you see the discrepancy between the ERG and the EOG, EOG is completely undetectable, while the ERG is reasonable, not completely, polished. You would be able to, to make the diagnosis properly if you suspect something, and then you direct even the investigation accordingly. So that, that's very handy when it comes to phenotyping. Again, another utility for ERG that we actually don't really pay attention to is patients who are being monitored. And say, for example, patients with epilepsy, which is, I think, is something that we should be able to help with. I don't know about the percentage of patients who are, for example, treated for epilepsy with Ba-Abbad. Nobody has ever referred a patient to us saying this patient is on Ba-Abbad, can you check for retinal toxicity? Which is also something that we should be able to help the neurologists with, because we should be helping other subspecialties with their patients. And last and not least, once we start, clinical trials for any other treatment, I know that ERG is not that helpful in RPE 65 because they start off with undetectable ERG. Even after successful treatment, the ERG is undetectable because the ERGs are supra-threshold tests. Then you should be able to use, psychophysical tests to actually detect if there is an improvement and whether the effect of the treatments is sustained. But in general, if any trials are available, then you should be able to have a pre-treatment and post-treatment ERGs to compare. And this is part of the licensing for any new intervention and medication. And I know Dr. Al-Hazza is also having a vested interest in diabetic retinopathy, for example. The world is your oyster when it comes to even ERG data in diabetic patients, because there are quite a few diabetic patients, even before showing any signs of diabetic retinopathy. AI might say other way around, but for the humble clinician like myself, diabetic retinopathy is also a form of neuropathy when it comes to the retina. And you should be able, before any treatment trials, for example, new anti-VEGF or something, to actually have baseline ERGs and follow-up using those data. So it's really an important tool. I don't think that it will be out of fashion anytime soon. I hope I answered your question, Dr. Al-Hazza.
Yes, more than that. Thank you very much. You're always just, you're a wealth of and a depth of knowledge. Thank you very much, Dr. Rola.
Pleasure. It's an honor. Thank you so much. Dr. Abrar Salama said how to deal with incidental findings not related to the eye in the genetic report. So this is something that, again, is part and parcel of treatment, treatment as well as the fellowship training of an IRD specialist. So this is not something that I could answer immediately, but if you are in doubt and you have an incidental finding that the family should be alerted to, I suggest that you do not break the news to the family, because it becomes really confusing to them. Now we're dealing with a child who doesn't see, but now this child is a carrier for a Batten disease gene, for example. So that's something that I would encourage you, once you come across something like this, to refer the patient to a clinical geneticist to handle the breaking the information, and also maybe doing further segregation analysis for the family to find out more about this. So, and again, incidental findings, even mutations in BRCA1 and BRCA2 are not always associated with cancer. So you have to be able also to differentiate, and therefore I do not encourage people to take this step of doing this on their own unless they have the proper training and certification.